there is not much enthusiasm. So, from the SCCM Consensus Conference, a level 2B, grade B recommendation: do not use prophylactic systemic antibiotics or antifungal agents in patients with necrotizing pancreatitis, and routine use of selected gut decontamination is not recommended. Most patients will resolve in a few days. We do not need to get nutritional support into these patients immediately. It is reasonable to wait 7 days of NPO. Some people wait even longer if parenteral nutrition is required to give intravenous fat. Severe or prolonged pancreatitis, many of these patients will get ileus, and that is a conundrum in parenteral versus enteral nutrition discussion. However, most of the data suggests that the incidence of organ dysfunction, the incidence of infected necrosis, the incidence of the requirement of surgical debridement, and the incidence of mortality is lower with enteral nutrition than with parenteral nutrition in severe acute pancreatitis. The problem with this study is that they all received antibiotic prophylaxis, and that's probably not indicated. But the best data that we have suggests that we should be trying at least to feed these patients enterally. It used to be that we performed early and aggressive surgical debridement. The pendulum has now swung to trying to not operate on these patients, and certainly not operating to debride sterile inflammation. We operate late for pseudocysts if they don't involute after 6 weeks, usually with parenteral nutrition. And so the diagnostic test of choice for patients who develop organ dysfunction or who develop a fever more than a week after the onset of pancreatitis, when patients do get into the window where infection is a possibility, is to do a fine needle aspirate. And that means to perform again the CT scan with pancreas protocol as we discussed, and if there is a fluid collection or a devascularized portion of the pancreas, do a needle aspiration and send that for culture. Historical indications for surgery were greater than 50% sterile necrosis of the gland, persistent necrosis, the development of organ system failure, or a deterioration in the clinical course. The pendulum has swung away from this, and now we operate really only on proved infections, and we try to delay that operation for as long as possible so as to allow the devitalized portion of the pancreas to demarcate from that which is still alive. So in this study, randomized to early versus late pancreatic necrosectomy, the early patients were debrided within 48 to 72 hours, and the late patients were debrided after more than 12 days. The mortality rate was essentially double for those patients who were operated on early. So we're now reluctant to operate on these patients, and when we do have to operate on these patients, laparoscopic cholecystectomy accepted, we tend to operate late. We do not have class 1 evidence here, and so a lot of this is going to depend on the experience of your consultant surgeon. There is interest in doing so-called minimal access approaches, opening the lesser sac with the laparoscope, the old days of open debridement and going back every day or every other day. My personal record from the early 1980s is operating on one of these patients 18 times. But nowadays, the mean number of operations that these patients get is 1. By waiting so that you know what's alive, you know what's dead, and you can take care of it all in one operation. So neither the presence of pancreatic necrosis nor its extent per se are an indication for surgical debridement. This is a little bit hard to see, but basically what this algorithm says is that if you suspect that the patient has a pancreatic infection, you do a fine needle aspirate, and then fine needle aspirate is positive, then you consider operating on patients. So we've spoken about recognizing patients who have severe disease, whether or not to do an ultrasound or a CT. We've not gone into detail about monitoring or resuscitation, except to say that the 15% of patients with severe pancreatitis can be among the sickest patients that you will ever have in your intensive care unit. And evidence-based analysis now does not support the use of routine antibiotic prophylaxis for these patients. There's no role for ERCP in a non-jaundiced patient, no role for early debridement. We try to wait to intervene, and we try to intervene as minimally invasively as we can. And so the pendulum has really swung in the surgical management of these patients. Thank you very much for the invitation to address you.
Pre-pyloric rather than post-pyloric. The first, second questions about the type of feeding and TBN. There is a role for decreasing the levels, percentage in the intrathecal TBN feeding orders.
There's probably no optimal time to start that hasn't been defined, but certainly I have no qualms about waiting 7 days. Almost all of these patients are going to have some extrinsic compression of their duodenum, and it would be nice for some of that edema to resolve so that you can promote gastric emptying. We use erythromycin as a prokinetic agent to assist with gastric emptying. And because these patients are often on a ventilator and therefore subject to the ventilator bundle with their head in bed up 30 degrees, I have no qualms about intragastric feeding personally as opposed to post-pyloric feeding. We routinely feed into the stomach. I think you have to be as senior as I am to have actually seen a case of fatty acid deficiency. We just don't see it anymore, but I saw some when I was a resident in the 70s and in the early 80s before the 10% lipid emulsion became available. In a patient, for example, with inflammatory bowel disease who couldn't eat at all, and we started them on parenteral nutrition without fat supplementation, it took 6 to 8 weeks for those patients to manifest signs of fatty acid deficiency. So waiting 2 or 3 or 4 weeks to begin fat supplementation in one of these patients is not a problem at all.
Talk about estrogen diagnosis of syndromes, cystic activation of MI, and non-cystic activation of MI, and complications. So acute kidney syndrome involved about more than 2 million patients in the States. 1/3 with the segment elevation, which have different than other acute kidney syndrome that have elevated these segments. The other acute kidney syndrome, which include non-segment and unstable angina, they have ECG changes and some non-segment elevation have increased biomarkers. So patients who came to the hospital with acute kidney syndromes. So the first thing we have history, clinical history, and the ECG. If the ECG have ECG elevation, we diagnose as myocardial infarction. And if they have only some ECG changes, we do the biomarkers. If the biomarker is high, we diagnose them as non-putative MI or non-cystic MI. So, what's the major cause of vascular occlusion? Is atherosclerosis in the form of a plaque, which deposits in the coronary. So this plaque usually have fissures or ruptures or calcified plaque, which will lead to occlusion of the vessels. So when this plaque have ruptures or a fissure, so exposing the thrombotic agent in the atherosclerosis, which contain lipid, cholesterol, macrophages, inflammatory cells, exposed to the bloodstream and start to have thrombus accumulation and start to have thrombus formations, which could be the source of microthrombi showering all this thrombi to the in micro vessels leading to occlusion or partial occlusions. So what is the link this lake ruptures or fissures? Stress, physical exertions, inflammation or fusion of vessels. And most of this link including the vessels, which is less than 50% stenosis. So the occlusion not merely in the severe stenosis, but even in patients who have less than 50% stenosis, they can have occluded occlusions. This is which have a stable place, usually developed by muscular layer and a thin fibrous cup. The vulnerable lake, which is susceptible to ruptures, they usually different than the stable lake. They have a very thin fibrous cup. When this shear, when this fibrous cup broken, is all this content of the athrombus exposed to the blood and start to have this thrombus formation of thrombus. The troponin is the state-of-the-art biomarker in patients with acute pulmonary syndromes. Usually it indicates myocardial damage. It does not indicate that all patients having the troponin have MI, but it indicates myocardial damage. In the first presentation with troponin, this troponin could be not addicted and need to be repeated every 6 to 8 hours for 48 hours to be possible. That's when we have application with suggestive symptoms at the hospitals and repeated monitoring for later enzyme and ECGs. This is to compare the evolution of the therapy of the aspirin and the fibrinolytic therapy and PCI, compared to the other modalities. With aspirin and fibrinolytic therapy, it reduced the mortality compared to other therapies. So this is the question: you are traveling and suddenly experience substance chest pain, diaphoresis. You are taken to the local hospitals, and 2 hours later, an ECG showed a TLSC inhibition. There is no evidence of heart failure, no contraindication for thrombolytic therapy. Estimated low to balloon time is 120 minutes. What's the best course of actions? Giving this, okay. Primary PCA with a placement of a bar beta stent. Tissue plasminogen. Primary PCA with a placement of drug stent. Half dose of the phase along with glucocorticoid and inhibition and PCR. Which one? Huh? A? Okay. We'll go through the presentation and see if you change your thing. Okay. This is the time and the flow and sustaining the time and flow is very important and for a patient who have acute pulmonary syndromes. To regain the flow of the occluded vessels is the tissue factor. So it's the early time to have it, and the good flow, back to normal flow, and sustain the flow is very important in patients with the heavy mind. So this meta-analysis, which have about 50,000 patients who received lytic therapy in the first 30 minutes, it showed a significant decrease in mortalities. In the other study, which they have PCI within 90 minutes. The one who have a normal flow, a TII, thrombotic induced MI with a grade 3. This is the normal flow. So the one who have this one, they have reduced mortality by mortality to 3.7 compared to 9%. The one who have inverted flows. This is to